I was trying to think in my 10 minutes, do I put a lot of information and talk really fast, or less information and talk really slow? I think I've maybe hit the middle ground, so... Can you actually see me? Is that better? Great, thank you. What have we done with the money that we were allocated in the recent round of tenders? Well, we were allocated money for what we are calling now the Actioning, Recovery and Citizenship Program. This was previously our Resident Recovery Program. And one of the things that we talked about as a team while we were waiting for the tender process over those many, many months, stretching out, was if we had the opportunity to improve and to work on what we are currently doing, what would we do? And so we consulted not just with the team, but obviously with our consumers. And we also talked to other organisations and kind of said, what's working? What's not working? What could we improve on? In particular, we consulted with mental health services. And what we found was working really well for us was the fact that we were doing a very strong case management focus in the interventions that we provided for people. But we thought we could go one better, and we decided that recovery was merely recovery. What it needed was something else. And that was to actually have people participating as a full citizen in the community of their choice. And we felt that the citizenship component was something that was kind of there, but not really taking a focus. So when you look at people having hope and optimism, what are they having hope and optimism for? And it's really about connecting with community. So the aim of our program is to work with individuals with severe and persistent or episodic mental illness. That's the criteria under the funding. We had moderate previously, now we've gone to severe. And what we want to do is to actually look at targeting the interventions that we provide and the groups that we provide that fit in where that client is on their particular journey in recovery and help them to increase their self-management in their lifestyle, looking at their health needs across the spectrum, not just their mental health, but also their physical health and their social health and well-being. So what we wanted to do is look at how do we get people to get the skills and resources they need so they can break that cycle of shifting through acute mental health services, boarding house or hostel accommodation, and homelessness. I use the word boarding house and hostel accommodation because that's kind of what it is in the tender. However, any of you will know that hostel owners will always say they are supported accommodation facilities. So please think of that as an interchangeable term. So I guess that's our criteria for service. You need to have a severe and persistent mental illness or an episodic mental illness, and that you need to be residing in a boarding house or a supported accommodation facility. And in addition, we have been given the geographical distribution across the Brisbane metropolitan, so that's north and south of the river. Now, I haven't got a picture that says where exactly those boundaries are, purely because I'm really not sure. And no one's been able to give me a really clear answer to that. However, it's metropolitan Brisbane where there are boarding houses and hostels. I am kind of thinking more in terms of probably a local council, so Brisbane City Council. But what's most important, and as I said previously, it's about enabling clients to be able to access and exercise their rights of citizenship. We also want to encourage people and assist them to gain access to the right combination of supports at the right time. So whether that's the GP or specialist treatment, some Brett mentioned earlier about the life expectancy of someone who has severe and persistent mental illness and the complications or life-limiting conditions that they experience. And so we want to make sure that we are getting people connected well to the supports that are available to them. We want them to be able to self-manage both their mental and physical health and sustain their tenancy in an accommodation, whatever that is that they choose, and also to be included in the community. So we recognise the social determinants of health and the significance of community connection and participation. So what's the team going to look like? Well, this is kind of the breakdown, if you like. We actually haven't really increased our case managers, but what we've put in place as well to support that is key support workers and peer support workers. Our case managers will be doing a combination of things. They'll be doing case management, obviously. They'll also be doing care coordination, some supportive counselling, and they will be co-facilitating groups with peer support workers. The peer support workers will also be looking at consultation with our consumer groups and look at the development and design of new groups. Also of the development and design, I guess, of after an evaluation of where we're going with the program that we're currently running. So in 12 months' time, we'll evaluate how we've been progressing and look at what do we need to tweak, what do we need to adjust, what do we need to adapt. The key support workers will be very much doing the practical skills development. So whether they'll be doing some transport training or budgeting and shopping, cooking, general things like that. So what we're going to be offering is very much a strength-based needs assessment. That'll be your kind of point of entry. And not only the needs as we determine them to be, but the needs as the client determines them to be. We will be offering the opportunity to take part in wellness recovery action planning groups. All of our case managers and group facilitators will be trained, most of them are, but there's a couple who still yet to be trained as RAP facilitators through the Copeland Centre. We want to make sure that people have crisis plans. We want to make sure that they've got their recovery goals clearly articulated and that they are able to utilise these to work towards to strengthen their citizenship. So we provide case management and collaborative care. We want to get people to have a better sense of belonging wherever that is in terms of their accommodation, somewhere that they actually have as a home base. We want to co-design strategies to reduce the need for presentations to emergency departments or unplanned hospital admissions. And that's really about that connection with community and supports. We also want to be able to assist people to identify triggers and what are the stresses and get them linked in quite early with the appropriate services to and networks so that they can develop those relationships and have those supports when they need them. As I said before, we're going to look at practical day-to-day living skills and a range of recovery-oriented empowerment groups. So RAP is one, but we also run women's groups and Power Run for Women. We are very strong in looking at our health and well-being. So we will be looking at putting in a coaching program for lifestyle. So if you like, they'll all have the opportunity to have their own life coach and work from that kind of a model to how to enhance their capacity to participate in the community and to manage their health and well-being. The other thing is that we didn't want to come in with a suite of groups that we're going to say these are the groups we're going to be running apart from Power On and RAP. However, part of the peer support workers will be actually to consult what do you want as a group, what would be the most useful for you. So we will be developing up those groups over the coming months. So in a nutshell, we're basically offering case management and supportive counselling, practical supports and life skill development, and group learning and development activities and peer support. Now, one of the things when I showed you the breakdown of the team and how it would be structured, there are two positions that I haven't actually filled at this point in time, and that I'm still kind of tweaking and wondering where this is going to go, because I think there is a strong need for an after-hours weekend component. And I'm not sure how that fits, and I was kind of wondering what other people were going to be doing. So I think there has left me in a position now where we can actually explore some partnerships and working with other organisations to try and work out how we can meet that response, and that will be something that we'll be doing in the coming months. And I guess how do we know that we're doing a good job? How do we know that we're actually meeting our targets? And it was interesting, I did this talk for mental health at the Royal a little while back, and they went, KPIs, you guys have got KPIs. And it was, well, yeah, because we need to actually look at how are we tracking against what we're supposed to be doing. And so it really is that people are integrated, that they do have access to primary care and other services, that they've got the strategies they need to self-manage, that they can sustain their accommodation, they can participate in group activities, and as I said before, that they have a reduced number of unplanned hospital admissions or presentations in crisis at emergency departments. So we've recently just finished our recruitment at this point. We've moved into a new office. We're still trying to get the phones working, as you do, the IT. But we are ready to take referrals right here, right now. And on the Footprints website, the old resident recovery program still unfortunately is sitting there. We're catching up with getting everything shifted over. However, the new referral form you will find on that website, or send me an email, I will send it out to you. That's fine. Or you can just call us. Yeah, that's about it, really.